Hello, my name is Audrey Sagan, and I'm the project administrator for the Eileen McGeever Breast Cancer Survivorship Program that is in collaboration with the Bench with Bedside Initiative with Dr. Bodur Salia, who is an associate professor of translational genomics at the University of Southern California Keck School of Medicine in the Department of Cancer Biology. And the Bench with Bedside Initiative is an unconventional and collaborative approach between scientists and patients in the fight against breast cancer. The goal of the Bench with Bedside Initiative is to build a community through empowerment of knowledge, hope, and transparency across all sectors. We hope that you enjoy this webinar session presented by Dr. Maria Nelson. She is a highly accomplished surgeon with a wealth of expertise in the field of breast surgery. She's the chief of the Division of Breast Endocrine and Soft Tissue Surgery and an associate professor of surgery at the Keck School of Medicine of USC. She earned her master's and medical degree from the University of South Dakota and completed her residency training in general surgery at Santa Barbara Cottage Hospital. Afterwards, she completed her fellowship training in breast surgical oncology at Cedars-Sinai Medical Center. Dr. Nelson also serves as the Associate Program Director of the USC Breast Surgical Oncology Fellowship Program, and her clinical focus is in benign and malignant breast disease. And her current research interests include diagnostic role of breast imaging techniques and the complex nature of decision-making in breast cancer care. We hope that you enjoy this session, and if you have any questions for our research team or for Dr. Nelson, feel free to reach out to us either through our email at benchwithbedside@initiative@gmail.com, or feel free to contact Dr. Nelson directly. Her contact info is at the end of the session. We hope you enjoy it. Thank you.
So everyone probably knows somebody or has a family member who has been touched by breast cancer. It affects all of us. It's the number one cancer a woman might face in her lifetime. It's 1 in 8 women, or 12% lifetime risk. This is a risk that doesn't start at age 20. It accumulates and kind of peaks in the 7th decade. As you age, the risk of the breast cancer can go up. And then there's sort of this inflection point after this age 70, where there's other competing factors for a woman's health, such as stroke, heart disease, etc. So what kind of changes might someone find if they were to have a breast cancer? If there is a physical change, it might be a lump or a pulled in nipple called nipple retraction, or dimpling or thickening of the skin. You might see a bloody nipple discharge or a rash that doesn't go away, or just frank thickening of the skin. These are all physical exam changes that might indicate something worrisome for cancer. However, some people may never see a physical change. It may just only be seen by imaging, which is why imaging is so important. So here's some example pictures of a mass on imaging, the nipple discharge, that thickening of the skin. Sometimes they'll call this peau d'orange, which is like the orange peel appearance of the skin. Moving into breast screening, an average risk woman, which is defined as a less than 20% lifetime risk, usually starts with a mammogram at age 40. And the mammogram should be continued yearly. Self-exams are a bit optional, but I've never told a woman never touch her breasts. You don't have to, but if you can be familiar with your breast and know what the typical norms are, and if something were to change, you can alert your doctor sooner. High-risk breast imaging is defined as a lifetime risk greater than 20%. And you might be wondering, how do you know if your risk is over 20%? Well, there's tools such as software tools that are now added to breast imaging reports that will calculate a woman's risk of breast cancer over their lifetime. And these are not perfect tools. One that comes to mind that we use quite frequently is called Tyrer-Cuzick score. And this software tool takes a woman's age, their height, weight, their breast density, which is found by the mammogram. It takes a woman's family history, specifically breast ovarian history. If one a woman's had a biopsy that's shown atypia, that can all contribute to raising this number. And if you're at 20% or higher on this risk calculation tool, then the letter from imaging or your doctor would discuss that you may benefit from additional imaging. What that additional imaging means is contrast imaging, and that can be a contrast mammogram or a contrast MRI. Typically, this would be alternated with the routine mammogram, and so each are done yearly, but likely 6 months apart from each other. Also, if someone has high risk, you may see that they're starting earlier, such as the age of 30, and continuing this forward. So breast imaging, the backbone of our breast imaging is still the mammogram, for better or for worse. The older technology is the two-dimensional technology. The newer technology is the 3D or tomosynthesis or digital breast tomography. Those are other ways to say the 3D technology. The basic difference is that the 3D technology is doing 1 millimeter slice pictures through the breast, so it's creating some better clarity. This is a illustration picture. I'm not sure if you can see my mouse, but this is the two-dimensional one picture, and then the three-dimensional gives you all these slices, sort of like the books that little children will have where you fan the pages and each page is slightly different and it looks like an animated film. That's how the 3D pictures work. The three virtues for the 3D is that it is better to see through dense tissue, which is this white change in the breast. That's the glandular component. And it increases the detection of more cancers better than that of the two-dimensional. And then ultimately it has fewer callbacks, so less need for additional pictures because it's starting off with a higher quality picture. I often will tell my patients that dense tissue is like clouds in the sky. So this is a mammogram showing dense tissue. Here's the clouds, here's the blue sky. In this analogy, the blue sky is going to be the black or the fatty tissue. So you can say, what are we looking for? Well, cancers can look like white masses or white airplanes. And so if you have a lot of clouds or a lot of density, it's going to be harder to see the white object. So this is just the actual mammogram comparison, the side by side. And you're going to think, oh, the doctors, they're labeling people like fatty. Well, that's the description of how much breast to glandular tissue. So that's what density is. It's the ratio of the fat to the glandular. The fatty, remember, is going to show up more of that black. So you can see here it looks more gray, more dark, and you can see less white pattern. This is an almost fatty breast, which this description, if you look it up, will be letter graded, so A, B, C, and D, and then there's word phrases that you'll see on the report in front of density, and this is on the doctor report where they'll tell you. And so an almost fatty breast has a 0 to 25% glandular, which is this. Then the notch above would be scattered fiber glandular, which is this one, which is the 25 to 50% dense. Then you'll have a mixed density, which is called heterogeneously dense, like this. And then you've got the extremely dense tissue, which is your 75 to 100% dense. And you can see it's much more white in composition. Now, how would someone get a needle biopsy? Well, there's 3 different ways to do a needle biopsies. There's the ultrasound guided approach, which is the most convenient or less kind of traumatic for the patient because they're laying on their back and the ultrasound probe is just pressing against the breast. Then there's a stereotactic biopsy, which is a mammogram guided biopsy, and that's sort of like in the middle for the least discomfort. And you're getting squeezed with the plastic plates of the mammogram. And then third and final is the MRI guided biopsy, which is when you're in the MRI machine getting the needle biopsy. The tissue sample is extremely important to not only make the diagnosis, but also to guide treatment, to understand what kind of tumor is being present, and then how does it behave. We get molecular markers like the estrogen receptor, the progesterone receptor, and the HER2 protein marker. All of those can be analyzed from just this small needle sample. Now, when you look at surgical treatment, which is my expertise, there's really broadly 2 ways to approach the breast and 2 ways to approach the lymph nodes. The way to approach the breast is through a lumpectomy. We can call this a wide excision or a partial mastectomy or a segmental mastectomy. All of these essentially mean the same thing, that we're preserving the breast but taking out the area of cancer. And when we're approaching a cancer, we're thinking a negative margin, which means we want a small rim of normal tissue around the tumor. We don't want tumor being left behind or touching the borders of the cavity. If someone has a larger cancer, or maybe they have genetic risk, or there's some other, changes in the breast that we're worried about, some people will pivot towards mastectomy. Mastectomy is removal of the breast tissue. It's not complete removal, but it's maximum removal of breast tissue. And there's three ways to do a mastectomy. There's the simple or total mastectomy, where you're usually not getting reconstruction. Then there's the skin sparing approach, where the nipple areola and breast mound are being removed. And then there's the nipple sparing approach, where the entirety of the breast, but leaving the skin nipple, are left behind. And then when you look at the lymph node surgery, there's two ways we can check lymph nodes. The first way and most common way is the minimally invasive technique called a sentinel lymph node mapping and biopsy. And this typically is yielding 1, 2, or 3 lymph nodes, but sometimes can be a little bit more. And then there's the axillary lymph node dissection, which is a wider removal of lymph nodes in the armpit. And you're taking out essentially level 1 and level 2 lymph nodes, which on average are 10 to 20 lymph nodes. The biggest side effect of the lymph node removal is something called lymphedema, which is characterized by arm swelling. And this is a lifetime risk after an insult to the lymph nodes. If you're wondering how big of an insult risk is that for a sentinel node, it's about 5% lifetime risk of arm swelling. If someone's doing an axillary lymph node dissection, the risk can go as high as 30%, possibly higher if radiation to the axilla is needed. So this is just a cartoon illustration showing a lumpectomy where we're taking out that tumor with a rim of normal tissue. How do we localize a lesion if we can't feel it? This comes back to kind of three broad approaches that we have. The one that's been around the longest is a wire localized approach. So essentially the woman prior to surgery is going to the imaging center where the radiologist is introducing a wire in through the lesion, or possibly bracketing around a wider area. Let's say they have calcifications, you might bracket around it. I will tell the ladies that this is kind of like a pilot landing a plane. You know, when you land the plane, the pilot needs to be on the tarmac between the lines, so they're staying on track. So this, for the surgeon, is the way to identify where is that lesion and how do we stay on target to be as precise as possible. In the middle, you'll see this machine on wheels. Maybe it looks like a little bit like a microwave oven with a computer monitor on top. This allows us to take a picture of the tissue that gets removed. And you can see in the upper right-hand corner, this is a lumpectomy specimen, and I've outlined in the red the tumor with the clip. So this clip and this clip is what I put on. This is the originating biopsy clip that gets placed at the time of the diagnosis, and then the wire going in. You can see the area of change for the cancer, and then you can see this cuft of normal tissue. And this is just a cartoon illustration indicating the same thing, where we want that normal tissue around it to have a negative margin. Now, some people are getting nervous or get faint if they have a wire poking through the skin. And so we have new technology that are the wireless technology. So this is one of the examples of a savvy reflector. It's basically, it's not Big Brother watching you. You're not going to light up at the airport, but it will go in similarly in radiology. And then I take it out at the time of surgery. And the little clip has this monitor that looks like this in the operating room. And there's a probe. You can see the probe here. I can place that over the skin in a sterile sleeve, and it'll tell me how many millimeters below the skin is the clip. So it'll guide me to the exact location, which is quite nice. There's other technology that just came out in the more recent years called MagSeed or Endomag or Centimag. This is essentially similar to that Savvy clip, but without being a reflector, it's a magnet tool. So this box is what I have in the operating room, this probe right here. Similarly, it goes over the breast, and then you can see here this long kind of barb of the clip, and it'll tell me with magnet precision where is the clip or where is the lesion. So it allows me to find it without that wire in place. Now, pivoting to mastectomy types, we talked about the simple or the total mastectomy. That's indicated here, typically a larger incision. And again, the lady is typically not having any reconstruction. This is probably the least favored approach amongst the ladies I treat. The more favored approach is a skin sparing, which is in the middle, or a nipple sparing, which is indicated here. These dashed lines can be altered for incision placement. We're not obliged to go at 6 o'clock. We could like hide it down here at the fold of the breast, or we could put it on the side. So there's different techniques, but these two techniques, the skin sparing and the nipple sparing, are coupled with immediate reconstruction, and that can be either an implant or someone's own tissue called a flap. This is a cartoon illustration indicating the different types of reconstruction we have. So the breast implant reconstruction is probably the most favorite because it's just not another area in the body to heal from and lesser downtime to heal. Broadly speaking, the implant-based reconstruction is divided into two types. One is, or the first would be like the tissue expander, which is a deflated implant that goes in at the time of the cancer operation and then later swapped out to a final implant, or possibly as just a placeholder for later flap, meaning your own tissue being used. If someone's choosing to go with a flap, that could be done at the first surgery or potentially later in a delayed fashion. A flap just means you're taking tissue from the woman's body. Many times the ladies want to take it from their lower abdomen. Um, they'll view it or might describe it as a tummy tuck. It's much more elaborate than a tummy tuck, but it's a hip bone to hip bone cut. The belly button gets reshaped, and the skin and the fat on the lower abdomen is what's used to then bring up to the chest proper and created to make a breast. Some people are too skinny, so may need to use behind the shoulder blade. Some people will use it from the buttocks, and then there's also one not shown here, but some people will take the inner thigh called a pap flap if they don't have enough tissue in the other areas. Now this, sorry to be graphic, but this is an oncoplastic reconstruction. So this is a lady who is getting a lumpectomy, and they want that lift and repair of the defect. So often used in ladies who have larger breasts, who have more of that droop. We call this ptosis, when the breast is hanging lower. And then you can see that they get lifted. So they're agreeing to go smaller. The incision you can see here is around the areolar edge, going down to 6 o'clock. And what you may not see here is there's an incision all across the lower portion of the breast. So it kind of looks like an anchor or an upside down T. And that's how the ladies can have the defect fixed and also maybe get the lift out of it. Now, this is a cartoon illustration showing you the sentinel lymph node approach, which is that minimally invasive way to check the lymph nodes. There's two mapping agents that are typically used. One is a radioactive substance that goes in within 16 hours of surgery. The ladies typically don't like that injection because it feels like a bee sting, and there's 4 pokes. So it's a little unpleasant, and they're awake for that. The second injection is a blue dye. There's 2 different blue dyes, but that usually goes in when the woman's asleep, so they're not recalling that injection. What they do notice is they'll remember that their urine color is a magnificent blue-green, kind of like Scope mouthwash. It's a little weird, but that color can give us a color change of the lymph node, whereas the probe is correlating with the radioactive substance, where it'll give us a signal change. And that allows us to target the very first lymph nodes that are draining the breast. Keep in mind, we're not interested in these later lymph nodes, because if cancer's on the move, it's going to go to the first lymph nodes first. And we have found that if these are negative, we don't have to take the other lymph nodes. And that decreases the risk of that arm swelling we talked about called lymphedema. So the future of breast cancer has entered this new era. A lot of emphasis on the analysis of the human genome and the biology of the tumor rather than just the gross anatomy. Um, there's personalized medicine happening, genomic profiling of both the tumors and patients themselves. With genetic testing, there's targeted therapies such as HER2-directed therapies, immune therapies such as the pembrolizumab for the triple negative breast cancer. Artificial intelligence is being used in the imaging of breast imaging, de-escalation of surgery. You saw a little bit of that with the sentinel lymph node, or even further taking advantage of the new research that's showing some women don't even need a sentinel lymph node. So you're seeing even omission of the sentinel node surgery directly, and just more advancement in the nipple sparing and the minimally invasive approaches. Next generation hormone therapies with the selective estrogen receptor degradation. And then cancer vaccines are now being looked at as potential targets. This is not the ultimate conclusion of my talk, but kind of the conclusion on the breast cancer surgery portion. Just remember that the key to breast cancer survival is early detection. So if you or a loved one has not had their mammogram in the last year, please go get your screening mammogram. And if something changes, please talk to your doctor about it. This next part of my talk is going to highlight some new things at USC. Specifically our high-risk clinic and the use of those Tyrer-Cuzick scores that we mentioned earlier. I'm going to talk about Dr. Ito, our research scientist, his research. We have launched a new survivorship clinic led by Ron Stein, one of our nurse practitioners in medical oncology. Lymphedema surgery that's being done, our satellite locations, and then a new partnership that we have with MIDI Health, which is an online platform for telehealth. So the high risk clinic has launched about 2 years ago. It's run by our nurse practitioner and PAs. So right here are the 3 ladies that are on the main campus. We have a 4th person up in Santa Clarita with our provider, Dr. Woodworth, up there. So there's 4 in total, but these 3 work on the campuses of Keck, Verdugo, and Arcadia. This was motivated in part because the breast imaging, the mammogram, ultrasound are now adding this Tyrer-Cuzick score to everyone's breast imaging report. So they're identifying women who have that 20% or higher risk. And what we found is a lot of the primary cares or the patients themselves are telling us that, well, my doctor doesn't do a breast exam, or I don't know what to do with that information. Like, no one's able to order me more imaging or discuss potential genetic testing, or, they're not getting an active breast exam. And so for all of those reasons, we've started this clinic to address those questions and allow for a place for women to come and seek information. They don't have to stay in that clinic ongoing, but if they choose to and want their care, their breast imaging care centered in this high-risk clinic, we can do that. So all of this can be done in those visits. In terms of the breast imaging that we offer, obviously there's the 3D imaging that's being done. You don't have to ask for it when you come to a USC site. They will always default to the 3D imaging. But if a woman is eligible for contrast imaging, there's breast MRI, there's contrast enhanced mammogram. Some people will ask, well, what's the big difference? An MRI is a magnet, and you lay on your tummy with the breast in these circular openings with the head on an open massage pillow looking to the floor. So some people can't be in a magnet because they have maybe a pacemaker or metal in the body that's incompatible with an MRI. Some people just simply can't tolerate laying on their tummy. So then a contrast mammogram can be done where you walk up to the mammogram. There's contrast injected through an IV that's placed in the hand, and it's about 15 minutes per breast. We also have targeted and whole breast ultrasound. So targeted ultrasound is ultrasound that's looking at a specific site in the breast, whereas whole breast ultrasound is scanning all four quadrants, including behind the nipple. And this can be done in a screening fashion. Usually the ultrasound is partnered with the mammogram. So ladies who have extremely dense breasts, they might benefit from adding the whole breast ultrasound to their regular mammogram. Dr. Ito is a PhD and MD. He has his background in immunology. He has a research lab over at the Norris Cancer Hospital and is conducting phase 1 trial for metastatic breast and melanoma cancers, where he is injecting the tumor specific with chemo agents and targeted agents to see the responsiveness. He's also developing phase 2 clinical trials, looking at the immune response and blending that with radiation. And then he's also collecting data on high-risk patients. So these are well women that may have high risk identified by the Tyrer-Cuzick score or family history of breast cancer, and collecting data on them. Forgive me, my dog is coming in to say hello. Survivorship clinic. This is Ron Stein. If you know him, he's wonderful nurse practitioner under the medical oncology division or group. He is now started in the last few years a survivorship clinic. So women going through their breast cancer care often have a number of, kind of baggage from the treatment. And so he will see these patients in survivorship clinic and try to address the various issues that they may be struggling or dealing with. Lymphedema surgery. We've recruited 2 fellowship trained microvascular surgeons that have expertise in lymphatic surgery specific. The way we've been using their skill set is in cases where women may be facing an axillary dissection, which is that bigger surgery where we're taking out, 10 to 20 lymph nodes. I can identify these patients and have them see Dr. Dar or Dr. Kester in advance of surgery, where they will be there at the time of surgery and then provide immediate repair of the lymphatic channels back to the venous structure. So under a microscope with really fine suture material, they're sewing the venous structures back to the lymphatic channels that got divided. And this is our attempt to reduce the future of the lymphedema. It doesn't reverse it, but our hope is that it can diminish the risk of that future lymphedema. We're also partnering with occupational therapists, so everyone's getting pre-screened ahead of this surgery to be seen and measured by an occupational therapist. Now, some people may have lymphatic issues that predated this, ability to kind of fix it on the spot. And so they will see people with chronic lymphedema or issues maybe in their lower extremity lymphedema and can try to address and fix some of that lymphedema surgically. So there's kind of a broad array of different patient populations they might see, but in the breast world of what I see, we're trying to combat it right away at the time of the insult. We have satellite locations. Often people will think of us as the Keck location. This is our HC3 building, which is kind of nestled right outside of the Keck Hospital. It was built in 2018, and we're on the 3rd floor providing surgery and medical oncology breast services along with the imaging department. We have Arcadia Hospital that was acquired a couple of years ago by USC, and in the adjoining buildings kind of near campus, there's a freestanding surgery clinic, radiation clinic, and medical oncology clinic. Over at Verdugo Hills Hospital, that's where I primarily go. There's a clinic in front of the hospital, and then there's surgeries being done at the hospital for breast cancer patients. And then Henry Mayo is a venture that USC has a joint venture with Henry Mayo up in Santa Clarita. We have a wonderful breast surgeon up there, Dr. Amanda Woodworth, who services that community. She's just a rock star. We love her. and she's doing the high risk surveillance as well as all the breast cancer treatment that we do at the main campus out in Henry Mayo. She'll sometimes even bring some of her cases down to Verdugo or to the Keck campus. This is just a map showing up in Santa Clarita where Dr. Woodworth is. I'm here at the Verdugo site and at the main campus, and then we have Dr. Siegel here going to the Arcadia site. Our most recent partnership is with MIDI Health. I don't know how many of you have seen this, but it's a virtual or a telehealth company that has various specialists that are poised to address the perimenopause, menopause. They'll do survivorship. So after cancer diagnoses, they'll do just the well woman who's maybe experiencing changes. It is covered by insurance, and they partner with the USC Keck medicine. So if someone's needing an in-person visit or a mammogram referral, they will refer back to the USC system. So that's a very nice partnership to have and can address a lot of the concerns that women have in midlife. This is just a photo of our team. You can see our surgeons here kind of in the back, and then our ancillary support team and our nurse practitioner and PA team. Well, thank you. This is just my email address and phone number, and then I'm going to stop sharing and open it up to questions. All right, can you guys see me back again?
Almost. You're still sharing.
Oh, forgive me.
There you go. Thank you so much, Dr. Nelson. That was very informational. And if anyone has any questions for Dr. Nelson, don't be shy. You can turn on your camera, come forward. Anyone have any comments? Dr. Nelson is wonderful.
Thank you.
I think you have some of your former patients here.
Yeah. You guys are probably all experts on this.
Anyone, I'm actually curious from the audience if anyone learned something more about a treatment that they received that they maybe was communicated a little differently to them during their treatment. For me, my mom is actually a breast cancer survivor. So a lot of what you talked about, I'd actually never knew about that treatment. And it's,
Oh,
yeah,
okay.
and a lot of it has changed. So she was diagnosed almost 20 years ago. And so there's just been advances in the care.
Yeah. There's a big emphasis on trying to catch people and triage them into, the low risk or high risk. And so we can try to get ahead of it and diagnose and screen them more aggressively. Some of our high risk ladies will even opt to do risk lowering medicine. And you might be wondering, what's the risk lowering medicine? It's we call it baby tamoxifen. And if you're familiar with some breast cancer treatment, you might say, I remember tamoxifen. That's that anti-estrogen pill that the cancer ladies get. Well, they usually dose that around 20 milligrams, and the baby dose is a 5 milligram dose. And you might say, well, why would ladies who don't have cancer, why would they take that? Isn't that going to make their menopausal symptoms worse? It could, because that's the side effect of tamoxifen. It's a selective estrogen receptor modulator and inhibits the estrogen effect of the breast, and that's where we see that the risk of breast cancer can go down when women are on that. The issue is that the ladies don't want to inherit the potential or perceived side effects of tamoxifen, which can be, the irritability, the hot flashes, the cognitive fog, the pesky 5 pounds that are hard to shake, like those kind of issues. I think they get more worried about. But some people are very motivated, and then they'll be on that daily for 5 years to lower risk. And common after, say, like a diagnosis of some atypia or something called LCIS, which is lobular carcinoma in situ. These are changes that are under this category of like high risk or borderline risk lesions. Sometimes people want to call them precancers. I would not use that word because I think it's more confusing. But essentially, those are kind of the targeted population that would be having that conversation of potential medicine along with the imaging tools.
Wonderful, thank you.
Well, you guys, thank you for coming.
Thank you
Any
so much.
questions, I'll stick around.
Yeah, we'll stay on for a couple minutes. Anyone have any questions on our research project? I know some of you are research participants as well. Yeah,
There's,
no
if you
worries.
have medical oncology presenters, there's a lot more medication trials that are happening. So in the world of surgery, there are fewer active trials, as you can kind of see. But we partner with the medical oncology group, and then there's active enrollment
Mhm.
for the medication.
Yeah. Sarah, did you want to say something? Go ahead.
Yeah, I just want to say hi to Dr. Nelson. I'm her
Hi,
patient,
Sarah.
but I'm at the point where I don't get to see you anymore, so it's so great to see you.
Good to see you too. You look well.
Thank you. There's a question
Someone's
in the
asking, do
comments.
you
Sorry.
do flat closure? Sorry, Sarah, did I interrupt you? No? Okay. Do we do flat closure? Absolutely. There's two ways to do flat closure. So I can do a flat closure where it's a horizontal or a diagonal. But when people are using that term flat closure, usually they're meaning like a cosmetic flat closure, something less in that traditional horizontal or diagonal. The way we do it at USC, because there's kind of a couple of ways you can do it. You might find that your breast surgeon like me would do a cosmetic flat closure, or you could partner with plastics. I like to partner with plastics because they're a little bit more creative and they can kind of really figure out what the patient wants. And what I have noticed with the cosmetic flat closure is the ladies are typically favoring a what looks like an upside down T. So they're getting a little bit of that horizontal pattern, but they'll have like a vertical. And what they'll do is the plastic surgeons will take some of the skin that's being saved and they'll take the top layer of skin off. They call that de-epithelialize. And they'll fold that dermis layer down. So it kind of looks like a prepubescent or pre-puberty kind of chest, and you're going to say why, but they're kind of getting that little bit of a fold in the bottom where the flatness is happening at the top, and that way they feel like there's a little something there, but they're not completely flat. Other times the ladies are just more interested in getting rid of some of this excessive like redundancy on the sidewall, which we used to call a dog ear, which is a really bad name for it. So we now call it an angel wing. But regardless, like even though we make it a nice sound like an angel wing, the ladies usually don't like that redundant tissue. And so sometimes that's the goal for the cosmetic flat closure. They're trying to bring over some of that tissue, make it flatter. And then, whether or not they want that pre-puberty look or just something that's going to fit nicely with a prosthesis. So it's sort of an individualized conversation. I'm now partnering with plastics to offer that. And then what that looks like is in the pre-op holding area, the plastics partner will draw on the skin exactly what their pattern of like what they want to leave. And then I work within the confines of that incision pattern. Does that make sense? So then I'll take and get the breast out, the nipple areola out, and then they will come in once I'm done getting the breast out, and they will bring that skin back together in the fashion that was discussed and approved by the patient. Does that make sense? Oh, good. There's a couple questions. Thank you for sharing about the baby toxin. I'm actually wondering if the Tyrer-Cuzick score is used at other cancer clinics. I think there's a real uptick. So I believe UCLA is adding the Tyrer-Cuzick score to all the imaging. I'm not sure about Cedars. I haven't seen a current report. But what is on the horizon is that right now CMS, which is one of the governing bodies for kind of regulating breast imaging and best practice, they're encouraging breast imaging centers to add it, but they're not making it required. I think what you're going to see in the next 5 years is that they're going to require it. Tyrer-Cuzick score still has some issues, meaning it can, raise someone's risk, I think, higher than what it ought to be just because there's some natural biases in it, but it's the best tool we have. Does that make sense? how long do you have to worry about triple negative after surgery, chemo, and radiation? Usually we're talking about the first 5 years are critical. That doesn't mean you're just scotch-free after 5 years, but the first 5 years is when we tend to see higher chance of a return of cancer. That's an excellent question. If you guys want a Tyrer-Cuzick score done, you can ask your provider to do it, or you can, self-refer to the high-risk program. We call it like the worried well woman. You might say, I'm not a worried well woman. I'm just a well woman. That's fine. But meaning like we accept ladies that may not have that definition of a 20% or higher. Maybe they just are a curious person. Maybe they have some dense breast tissue. Maybe they're, wanting that risk calculation or want to ask about genetics, or maybe they're interested in adding, whole breast ultrasound to their mammogram. Any and all of those are appropriate. We can see them. You do not have to have your primary care refer you in. A lot of the times we'll have the patients themselves self-referring.
And then what are the types of like interventions that you would do for someone who's in the high risk clinic? Like, is it just early screening with imaging, or do you offer like other life?
Yeah, so there's sort of like three things. They get a formal breast exam, they get a review of whatever current imaging or potential imaging that's appropriate for their age, their risk factors. They have a discussion of genetic testing. Not everyone is interested in genetic testing. And it's not always appropriate for them, but some people like to pay like out of pocket and not do like a 23andMe. I'm not picking on 23andMe, but maybe they want a medically robust genetic test sent. So they'll talk to them about that. And if you're curious, it's usually around like $250 out of pocket. But if insurance can cover it due to, family risk factors, sometimes you can get it fully covered by insurance. And so those are kind of like the three things: the breast exam, the imaging discussion, like what have you had done? Is there any supplementing with those other imaging tools? And then third, the conversation, if it's wanted, about genetics. And then that could be a one-off visit, or it could be, hey, let's keep you here and let's just keep the ongoing yearly, or let's do like twice a year where we're staggering MRI and mammo. Another question. Thanks for sharing. I'm on the third journey with cancer. First two were DCIS, and this one is an invasive. Appreciate your information. Well, thank you for being here. I wish you luck. I hope you caught it early and are on a good treatment pathway.
Great. If you don't mind, Dr. Nelson, just stick around for a couple minutes in case there's more comments coming through. But thank you everyone for joining live. This session was recorded, so we'll also post it, so feel free to share it. And we hope to see you again, Dr. Nelson, at some point to present again for us. But thank you, everybody. Have a wonderful weekend and enjoy your Saturday.
Bye, everybody.